A very good morning to all of you. This is Mokshada Kumar. I'm a final year PhD candidate in Dr. Dhaval Shah's lab at University at Buffalo. Today I'll be sharing with you guys my results of a recent study where we developed a PBPK model-based web application for the personalized dosing of monoclonal antibodies in pediatric population. Now, in recent years, the use of monoclonal antibodies has increased significantly in pediatric patients. These therapies are being used across a wide range of indications, which would include autoimmune diseases, cancers, infectious diseases, and genetic disorders. However, pediatric patients always pose a very unique pharmacological challenge where they undergo significant age dependent physiological changes. Now, this can alter the antibody PK and PD and therefore make direct extrapolation from adult dosing unreliable. As is commonly known, that pediatric patients are not just smaller adults. Even today, what adds to this challenge is that there's very limited available pediatric data for antibody PK. Even today, less than 10% of clinical trials include younger children. Now, only about 38% of approved antibodies have pediatric indications. This proportion would decrease further in children under 12 years, and only about 13% of approved antibodies can be used in patients less than 2 years of age, which really highlights how understudied this entire population is. Over the past 2 decades, there has been remarkable progress in our understanding of how age affects all these processes that are involved in antibody PK. Now, your antibodies are often administered through extravascular routes like subcutaneous or IM routes to pediatric patients, apart from the typical IV route that is seen. Once antibodies are uptaken into the bloodstream, they can mainly distribute into tissues via convection or fluid phase penocytosis. Now, since your antibodies are hydrophilic in nature and are also large in size, they would mainly reside in extravascular fluid. This figure from Nelson Textbook of Pediatrics shows that pediatric patients, especially your younger infants and neonates, have about twofold higher extravascular fluid available per kg of body weight than adults. This now indicates that there is more available volume of distribution in pediatric patients than in adults for these monoclonal antibodies. Similarly, a study of patients which were aged 7 months to 60 years in Northwestern University showed that there is increase in perfusion rate in pediatric patients as compared to adults. This would mean that there would be more distribution in pediatrics than in adults. Now, your extravasation of antibodies into tissues also would largely depend on capillary permeability, with more antibodies seen in tissues where there are more permeable membranes. Gamble et al. Found that younger children had 3 to 4 times higher filtration capacity as compared to adults, which could lead to much faster extravasation in pediatric patients. Now, once antibody has been distributed into tissues, it can be eliminated from the body via non-specific catabolism, target-mediated drug disposition, or ADA immune response. FcRn is known to play a pretty significant role in salvaging antibodies back into circulation from your endosomes. A recently published study indicates marginally higher FcRn concentrations in pediatric patients as compared to adult patients. Additionally, studies have also reported lower endogenous IgG concentrations in very young patients, suggesting less competition for FcRn binding by endogenous IgG. Now, there is limited quantitative understanding of how factors such as target abundance, turnover, or affinity internalization would really end up affecting would be affected by age, and also how the production of anti-drug antibodies is impacted by age. Now, while the impact of age on various processes has been widely studied, really the quantitative extent to which these individual age-related changes affect the final antibody PK remains substantially unclear. Now, there have been largely conflicting reports of impact of age on antibody PK in literature. This publication from Dr. Derendorf's lab highlights the prevailing confusion. Now, faster clearance was observed for antibodies like alemtuzumab as in pediatric patients as compared to adult patients, whereas we saw lower clearance for antibodies such as basiliximab. And there was no significant PK difference observed between adults and pediatric patients for bevacizumab. This confusion that is prevalent has led to really a large variety of dosing strategies being used to dose antibodies in pediatric patients. Now, for some antibodies, such as avelumab and tezepelumab, my apologies for that. Flat dosing is really used, and this is really the norm that is observed, especially when approval is limited to adolescents, whose physiology is much more closely resemblant of adult populations. Body weight based dosing is another approach that is used and is actually quite popular as it accounts for differences in body weight of adults and pediatric patients. One other popular method is body surface area based dosing. Now, while this has been used historically quite a bit, it has been losing interest in recent years, especially because of the increased complexity of calculating the body surface area in clinical practice. Other methods are tiered fixed dosing, which uses one or several body weight or age based cutoffs to define now these populations into different groups that would receive different doses. Now, in tiered body weight based dosing, adults may be given one body weight based dose, while younger populations might be given most likely a higher body weight based dose of antibody to account for changes in PK of antibody seen with age that would go beyond just size based differences. One other method that is observed is hybrid dosing, where your adults may be given like a flat dose, but in contrast, your pediatric patients would be given a body weight based dose just to account for the large changes in body weight or size seen in this population as compared to before. Overall, there is no single universally accepted pediatric dosing strategy for antibodies, and dose selection is usually guided by the available clinical data, the therapeutic window of the given antibody, and also the expected impact of body size and developmental physiology on the drug exposure. As a result, selecting an appropriate dosing strategy for a new monoclonal antibody can be quite challenging, especially when clinical data is very limited and you have less generalized understanding of the influence of age related changes on PK. This really highlights the need to better understand how age influences antibody PK so that appropriate dosing strategies can be selected for new therapies. Now, to better understand how age really influences antibody PK, we first compile clinical PK data for a very large set of monoclonal antibodies in both adults and pediatric patients from published literature and regulatory sources. Using this data, we then wanted to answer the question, does age impact PK? So we performed a non-compartmental analysis on antibodies for which we had both adult and pediatric data available, to then go and compare key PK parameters across different age groups. First, we observed that the dose and body weight normalized C0 values were consistently lower in children than in adults. Correspondingly, the central volume of distribution was much higher in children as compared to adult populations on a per kg basis, which really tells us that there is change in volume of distribution in pediatric patients as compared to adults, which goes beyond just size. Next, we wanted to evaluate the impact of age on clearance. For this, we then took body weight normalized clearance values between pediatric and adult patients and compared these. What we observed was pretty interesting that clearance increased with decreasing age. That was consistent across all antibodies. But interestingly, for antibodies which exhibited linear PK, we saw about 40% higher clearance in pediatric patients, especially younger patients below 2 years of age, as compared to adults. In contrast, for antibodies that exhibit nonlinear PK, now this effect was substantially more pronounced, with clearances increasing by as much as 2 to 4 fold in younger patients. Overall, what these findings really demonstrate is that age related PK differences are very pronounced in youngest patients, and these go much beyond the basic body size level differences. And they are also amplified in antibodies that exhibit nonlinear PK. Now, these observations suggest that dosing strategies that perform well in adults may not necessarily provide comparable exposure in pediatric patients, especially in those younger children, and you might need to use other approaches to be able to dose these patients correctly. This raises a very important question then. How can we really account for these age related differences when selecting antibody doses, and how do you select the right dose for pediatric patients? To really address this challenge, the objective of the work that we have done was to develop a pediatric PBPK modeling framework that can mechanistically characterize the impact of this age on antibody PK and then support pediatric dose extrapolations. First, for to realize this goal, we first expanded and generalized our lab's pediatric PBPK framework that incorporates age-dependent physiology using PK data from 13 different monoclonal antibodies post both intravenous as well as subcutaneous dosing. This helped us create a platform model that can then be used to mechanistically evaluate the impact of age dependent physiological changes and also extrapolate to dosing to pediatric patients. Finally, the next step was to facilitate broader adoption of the platform. Here, we implemented the model as an interactive web based application that allows users to readily evaluate these pediatric PK and different dose extrapolation scenarios to then find the appropriate dosing regimen for individual patients. In order to do that, our first step was to develop a mechanistic PBPK framework. The PBPK model structure that we used was consistent with the one that was used to characterize adult PK. Briefly, the model consists of 15 different tissue compartments, a blood compartment, a subcutaneous compartment for subcutaneous dosing, as well as lymph node compartment, which is all these compartments are connected to each other anatomically via blood and lymph flow. At the tissue level, each tissue compartment is further divided into vascular, endosomal, interstitial, and cellular compartment. The vascular subcompartment is divided into a plasma and blood cell compartment. Now, antibodies enter each tissue via vascular compartment and using arterial blood flow and exit via venous blood flow. Now, antibodies in plasma are distributed to the interstitial compartment either via convection or via pinocytosis. The vascular reflection coefficient over here represents the level of resistance that is provided to antibody convection by the vascular endothelial cells. Now, your antibody in plasma space is also taken up via pinocytosis. It is assumed that your intact antibody can undergo degradation or can also be bound to FcRn via K on or K off for association and dissociation rate constants. Antibody bound to FcRn recycles either to the plasma space or to the interstitial space via exocytosis. Now, antibodies that are present in the interstitial space are taken up by vascular endothelial cells via pinocytosis, or these can also exit the tissue compartment using the convective lymph flow and be circulated back into the blood flow. The interstitial reflection coefficient represents the level of resistance that would be provided to the antibody's convection by the lymphatic openings. Now, to capture the PK of antibodies administered via subcutaneous route, the skin was divided into two parts, one the skin and the other the subcutaneous compartment. The subcutaneous tissue, like all other tissues, was also divided into four subcompartments: your vascular, endothelial, and interstitial, as well as the cellular compartment. The subcutaneous dose is administered really into the interstitial region of the subcutaneous compartment. And additionally, we also have a first order degradation rate, local degradation rate rather, present within this interstitial compartment to account for any local degradation. We also added a scaling factor SL to the convective flow of antibodies from the interstitial region to the lymph node, which would account for various antibody specific aspects which lead to change in lymphatic uptake of antibody from the local post local dosing. Now, since pediatric physiology is very dynamic with age dependent changes in various parameters like body weight, organ weight, cardiac output, organ flow rate, hematocrit, and extracellular fluid, these changes were explicitly incorporated into the model. Yusun Ping Chang, a past PhD student in our lab, had conducted a very comprehensive literature search to really compile age dependent physiological data, which would include body weight, height, organ weights, blood flows, and hematocrit across the entire range of 0 to 20-year-old kids in both males as well as females. Now, using the collected data, she then developed gender specific mathematical relationships to describe this continuous change in physiological parameters throughout the growth and development of kids. Now, separate equations were generated for males and females for each type of physiological parameter, which allowed for physiological differences between sexes to be captured where appropriate. Now, using this mathematical equations, the PBPK model can then generate patient-specific physiological parameters such as organ weights, cardiac outputs, individual organ flow rates, and hematocrit from patient-specific inputs, including your age, body weight, and sex. In addition to age dependent changes in organ weights and blood flows, pediatric patients also exhibit much higher tissue water content as compared with adults. To account for this age dependent changes in tissue interstitial fluid, the changes in interstitial fluid fractions were also incorporated in the model, which really allowed developmental changes and antibody distribution to be captured mechanistically. Now, because monoclonal antibodies are often administered chronically over very extended periods of time, it was really important for us to account for changes in physiological parameters across these extended period of times. To account for this, the model dynamically updates all physiological parameters throughout the simulation time, allowing the age, body weight, organ weights, blood flows, and all other characteristics to change continuously. Now, this enables a very greater physiologically realistic representation of antibody PK in growing pediatric patients. Now, having incorporated all these age dependent physiological changes into the framework, the next question was whether these physiological changes were really sufficient to explain all the observed age related differences in antibody PK. To evaluate this, the model was fit to both adults as well as pediatric PK data from 13 different monoclonal antibodies. Importantly, now your age dependent physiological parameters were just generated directly from the equations that we spoke about before. While now antibody specific parameters were assumed to remain constant across different age groups. So each antibody, two key parameters, clearance uptake, which was the non-specific uptake rate, and KDEG, which is the non-specific degradation rate in the endosome, were estimated using available PK data across different age groups. As shown here, these parameters were estimated with reasonable confidence. For subcutaneous administration, PK data were available for only two different antibodies, mepolizumab and canakinumab. For mepolizumab, the subcutaneous specific parameters were estimated with reasonable confidence, whereas for canakinumab, the data was really variable at whatever doses were available. So, in order to be able to estimate properly, we just fixed these values to what was obtained based on the adult PK data. Overall, if you see, the model was able to demonstrate good performance with median percent prediction errors below 35% for all antibodies. that were tested. As shown here, the PBPK model was able to capture the observed PK across multiple monoclonal antibodies in patients ranging from approximately zero point 0.1 years up until much higher age patients like 16-year-olds and 18-year-old patients as well. For most antibodies, you can see that the model simulations closely align with the observed data across the entire time course. This indicates that now your key age-dependent physiological and mechanistic processes which govern antibody PK are well captured within this model. These are some additional antibodies and PK fittings for the same. Now, for antibodies where additional sparse concentration time data for multiple dose studies were available, these datasets were then used as external validation datasets for the model. Now, for each antibody, drug-specific parameters which were estimated previously were fixed, and the PK profiles were simulated a priori using patient-specific inputs such as the age of the patient, the body weight of the patient, as well as the gender of the patient. As shown here, the model was able to reasonably capture the observed PK profiles across multiple antibodies and across different age groups. The percent prediction errors were also within an acceptable range, supporting the predictive performance of the model. A marginal overprediction was observed for atezolizumab in infants, which did suggest that while the model captures part of the increased clearance in this population, maybe some additional ontogeny related processes may be needed to be incorporated. Overall, though, these results really demonstrate that the model has very good generalizability and can reliably predict PK within a mechanistic framework across different antibodies. Having demonstrated the predictive performance of the model, we next focused on that making a framework accessible to end users. To achieve this, the model was implemented as an interactive web-based application, which I'll briefly demonstrate now.